Other things. So we get, post-operatively now, we go through the rigorous molecular, analysis. We know the characterization of your tumor, and we have to think about how we're going to treat it now, right? And I was alluding to this before as well, but we want to talk about pushing the envelope in treatment, right? And so in the past, it was chemotherapy. You got a port, you got chemotherapy, right? But chemotherapy doesn't work in the brain, all right? The brain has a blood-brain barrier, and chemotherapeutics are very large molecules, and the blood-brain barrier says, absolutely not, you're not coming in here. So how do we devise ways to get around that, to deliver chemotherapies? Well, number one, we figure out what kind of tumor you have, and we decide what's our target, right? Can we target a certain, gene mutation, or can we target an overproductive protein, things like that? And then we think about how do we get the drugs there. And so John Bookfar, who's my senior partner, he's a brain tumor surgeon. He's been pushing intra-arterial therapy for probably 15 years of his life, and he just opened up a phase 3 trial for intra-arterial Avastin. And what this is the patient goes to the angio suite after their tumor is resected. We catheterize the arteries in their groin, and we send catheters all the way up to their brain, right? Looking on these little screens you see here, okay? We selectively inject blood vessels that are going directly to the area of the brain where the tumor was. And we use kind of, drugs or pharmaceuticals to open the blood-brain barrier and then deliver chemotherapy directly into the tumor. And not just the tumor, but its surrounding environment, right? And we know that glioma cells are invading, right? So all of a sudden we're treating not just the tumor, but we're treating that tumor environment, okay? And look, the drugs that we can use here are gonna vary based on what you have, but, and I think the last talk probably talked about this a little bit, we have to go through a process, right? We have to investigate, we have to take patients and we have to try things on them, we have to see who it works on and who it doesn't work on, and then optimize, and figure out exactly who we need to target, all right? And then other treatments we can do. So GammaTile is something I just brought in here. It's something called brachytherapy. So traditionally, what you would do is you would get your tumor out, you would go home and recover, and then about 4 to 6 weeks later, you would start treatment with radiation and chemotherapy, all right? But what if we could just radiate you right then in the operating room and start treatment then, right? Because, those 4 to 6 weeks, your tumor is growing. And let's say you have a very aggressive tumor, there's tumor cells circulating, they're changing, they're adapting, they're modifying, they're growing, they're replicating. So GammaTile uses cesium-131, which is it's a radioactive material. It's in a seed embedded in a piece of Duragen. Duragen is something we use regularly in neurosurgery to cover the dura. And now at the time of your resection, you line your resection cavity with these seeds, and they're delivering very high dose radiation to a very short distance, okay? And now any residual cells around the margin that's in that field are getting treated from day 0, the minute you're done with that tumor resection, all right? And the outcomes for this have been very, very reassuring. It's still not fully known yet what the best use is. I personally use this in recurrent brain metastases. I use it in patients who are going to have a hard time making it to radiation. People don't realize this, but radiation for a glioblastoma is 6 weeks. It's 5 days a week for 6 weeks. You have to come to a hospital, get radiated, and go back home. That's a huge chunk of your life, right? And so all of a sudden here, you can lay this in the resection cavity and you go home, and that's your radiation. You're done. That's it, right? It's a very big deal for, some of our underrepresented populations who can't do this possibly, right? It's a big deal for the elderly who may not have enough resources to come in and out. And truthfully, it's a big deal probably for everyone, because you're also targeting these tumors when there's the least amount of tumor left, right? I tell patients all the time, post-operatively, you have the least tumor in your body you're gonna have right now, right? And so now is when we wanna treat this, right? We don't wanna wait for stuff to come back, repopulate, go into different areas. That doesn't make any sense. We wanna treat you right now. And unfortunately, surgery, is the, it's like warfare, right? We're like in the Stone Ages with surgery. We try to fix people with steel and string, right? A knife and some string. It's goofy. And so the tech that neurosurgery has adopted, pre, intra, post-operatively, has really kind of pushed the envelope with all this stuff. And it allows us, even though we're just wielding sticks, to like still keep up with like the atomic age or biological or whatever you want to call it. It's like war. But anyway, these things are pretty incredible. There's really good evidence now that it extends recurrence-free survival, minimal complications, it's very safe, and there's less of a burden on the patient. And so I personally think this stuff is great.
Hey everyone. everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.